facilities, equipment, and the standards that we use. Aside from that, anesthesiology skill, of course, is very important. And sorry to say, but in all of this, we need to really make sure that we have a really good surgeon working with us, because otherwise, this will not bring us good outcomes. So in terms of anesthesia practice, we look at protocol, crisis management, the training that we give ourselves and our trainees, skills development, and continuing professional development activities. We need to look also at evidence-based medicine. We cannot do just what our seniors have done. We need to continue to study. We need to continue learning and going on with what is happening in the world. The goal is actually to provide the highest standard of care in safety in any setting. That is why in 2018, the international standards for a safe practice of anesthesia was promulgated together with the WHO and the World Federation of Societies of Anesthesiologists. And this ensured that there is access to safe anesthesia for essential surgery, and that this is a basic human right and should be available to all patients, irrespective of their ability to pay. So I urge everybody to please look at these international standards for a safe practice of anesthesia, because when you read through it, you will have that aha moment and find out within yourself whether you are really practicing anesthesia safely. So in terms of perioperative safety, we have a shared responsibility of the surgeon. It's not just about the surgeon or just about the anesthesiologist. We need to contribute together in making things better for our patient. So if anything happens, it is always a shared responsibility. Patient safety practices should ensure that we avoid harm. We avoid giving harm to the patient. And the basic issues actually in terms of this are ventilator-associated pneumonia, urinary tract infections, hospital-acquired infections, healthcare-acquired infections, and central line infections as well. I'm sure we don't think about this so much, but it is really part of the things we have to do to ensure that our patients are all right. So system issues are, when you talk about these kinds of infections, we need to look at system issues. It's not about human errors. So it's very important to talk about the adverse events per hospitalization. And this will be relevant for anesthesia and perioperative management, because as we discuss all of this, we will continue to prevent harm to our patients. And these safety practices will be supported by sufficient evidence that exists for their prevention. Post-operative infections, do we really look into this? Maybe we should start looking into this, because we really have a say, we really have a part in all of this. This is an area of concern in surgical patients, but it is not only about the surgeon's responsibility. This is actually a target for anesthetic and perioperative efforts. Post-operative pneumonia, did you know that this was increasing to 3.3% from 2005 to 2011? But we started doing multidisciplinary care. We started doing neuraxial blocks. We started studying pneumonia. We started looking at our cases as not merely beyond just within 72 hours, but even beyond that. We looked at surgical site infections. That is why we also have a role in the operating room in giving antibiotic prophylaxis, in ensuring normothermia, hand hygiene, the bundles of care, and the checklist. Of course, as the WHO we're in, we are very much a part of, preoperatively, intraoperatively, and postoperatively. We look at the airway-related complications. We make this an important patient safety aspect. And what was the problem in the project of the NAP4, the airways? They had no plan B in most challenging situations. Maybe that's why we have to start thinking about this. Technology was disregarded. So for those who think that video laryngoscopy should not be included in the armamentarium, they have to think twice. Technology should not be disregarded. There should always be a plan B for our patients. Airway management protocols were also not followed. We need to review this and make sure that difficult airway situations that go beyond induction can be addressed, that go beyond induction, that happen intraoperatively or even post-operatively. Of course, we make sure that there is early surgical airway attempt in difficult airways. We have the advent of the LMA, but it is not the be-all and all of airway management. It is not a fail-safe device. We look at patient extubation as a significant patient safety issue, and also at residual neuromuscular paralysis, which occurs in about 30% of patients. There is also an increased risk of postoperative adverse events, which expose patients to respiratory complications and can actually be prevented. We need to know about this. I'm sure we know all about this, but sometimes maybe because of the production pressure wherein we need to do a lot of cases, we forget to do the things we should. How about intraoperative hypotension? Did you know that intraoperative hypotension can contribute to organ injury, can cause stroke in our patients? These hemodynamic adverse events occur in in-hospital transfers of complex patients. Remember, up to 2050, we have an older population with more comorbidity. So we need to address these issues. We look at beach chair position, which is usually done, which can increase the risk of perioperative stroke. So it is important that the clinical management of hemodynamic events be addressed. There should be no silencing of audible alarms and no distractions or interruptions in patient care. So the Anesthesia Patient Safety Foundation was the key vehicle in promoting patient safety. And the crucial step was institutionalizing patient safety as a topic for professional concern. That is why we are looking at this now. So when we did this, I think this was the most important contribution because the APSF actually gave out quarterly newsletters. They gave out research grants for people who were interested in patient safety. But the default policy is, of course, that one that at face value seems to yield the maximum patient safety, then we should do it. So there is no single standard of safety for surgical and anesthetic procedures, but again, as we said, if we think that this will yield maximum patient safety value, then that is what we should do. We need to establish the patient safety standards, and since we have the international standards, we need to successfully implement this as safety strategies. We need to decrease the trends of safety issues and an absolute number and severity of complications, mandate constant vigilance. So use your M&Ms, use your adverse events to study our patients, to study how we can ensure patient safety. Remember that clinicians should retain what is gained, should retain what they have experienced in terms of adverse events. Limited resources, increased production pressure, as I said, may cause us to be more complacent, and active upkeep of established successful safety practices should actually be our cup of tea in order to ensure that we have patient safety coming all along. But although anesthesiologists made important strides in improving patient safety, there is still a long way to go. As it is, the overall reduction in negative outcomes related to anesthesia may not be as great as a drop in mortality resulting from anesthesia alone. Errors, mistakes, system failures continue to plague anesthesiology, and that is why we need to continue to study this. In fact, death or brain damage can still occur after hypoxemia. Esophageal intubation still happens, and this can happen from other easily detectable and correctable events. So we need, again, to be more vigilant when we take care of our patients. What else? There are standards, but these are not followed uniformly. How many of you, I'm sure, have problems in securing capnography in your institutions, and yet they allow laparoscopy to continue. They allow laparoscopic procedures to happen in operating rooms. They give the equipment to surgeons, but they do not give the equipment that we need to monitor our patients. Advanced simulation training is only available to a minority of anesthesiologists, but I'm sure our colleague, as our last speaker, will tell us how this can be as easily accessible to most of us. Clinicians still practice when fatigue, stress, or illness prevent optimal performance. And again, modern equipment remains beset by human error. Although there are a lot of good equipment, advanced equipment, new machines, please remember that you have to learn. You have to study the new machines before going into it in the operating room. So these are our patient safety priorities. These are the things we have to do. Preoperative assessment, anesthesia plan, you check your machines and monitors, prepare efficient workspace, check backup equipment, and label all your medications. Very basic, but certainly something we need to remember that we have to do all the time. In terms of your documentation, make sure there is documentation preoperatively, intraoperatively, and especially postoperatively in order to take care of our patients well. What about disasters? We are always blamed for everything. We need to make sure that anesthesia is not blamed for being early, for doing everything, for global warming. We're even blamed for all of that because of our anesthetics. But we make sure that we take care of our colleagues in as much as we take care of ourselves as well. We don't